Hi everyone, my name is Elizabeth Odynocki and I am a third-year medical student at LSU New Orleans. Today, my presentation will be based off of the article Müllerian Anomalies Revisited, which discusses the evaluation of Müllerian anomalies and focuses on the role of imaging in diagnosis and clinical management. My presentation is entitled Understanding the Embryology, Clinical Significance, and Imaging Evaluation of Müllerian Anomalies. So for some background, Müllerian anomalies occur when the normal development of the Müllerian ducts are disrupted during fetal development. These ducts eventually form the uterus, cervix, fallopian tubes, and the upper portion of the vagina. Patients may present with a variety of symptoms depending on the specific anomaly. Some adolescents may develop cyclic pelvic pain or primary amenorrhea because menstrual blood cannot drain normally. Others present later with infertility or recurrent pregnancy loss. Obstructive anomalies may also cause retrograde menstruation, which increases the risk of endometriosis. Because the clinical presentation varies so widely, imaging plays a central role in accurately identifying these anomalies and guiding the appropriate treatment. So for some background on the embryology of these anomalies, normally the development of the ducts requires 3 sequential steps. First, the paired Müllerian ducts must form correctly, and failure of this duct formation can result in anomalies such as Müllerian agenesis or a unicornuate uterus. Second, the ducts must fuse in the midline, and failure of this fusion leads to anomalies like uterine didelphys or a bicornuate uterus. Finally, the septum between the fused ducts must be resorbed, and failure of this final step results in a septate uterus, which is actually the most common Müllerian anomaly. And recognizing which developmental stage was disrupted helps radiologists accurately classify these abnormalities. So some current imaging approaches include ultrasound, which is typically the first line because it is inexpensive, widely available, and non-invasive. Specifically, 3-dimensional ultrasound can provide improved visualization of both the external uterine contour and the endometrial cavity. MRI is also valuable because it offers very good soft tissue contrast and multiplanar imaging, and this allows detailed evaluation of the uterus, cervix, vagina, and surrounding pelvic structures, which make it especially useful for complex anomalies. Hysterosalpingography, or HSG, is often used during infertility evaluations because it can assess both the uterine cavity and fallopian tube patency. So for some key evidence and recent advances, there are some guidelines known as the American Fertility Society classification, which was introduced in 1988. This classification has been widely used because of its simplicity and correlates strongly with reproductive outcomes. However, it primarily focuses on uterine abnormalities and does not fully classify cervical or vaginal anomalies. To address these limitations, the American Society of Reproductive Medicine introduced an updated classification in 2021, which provides a more comprehensive framework by incorporating all components of the female reproductive tract, which allows for more accurate classification of complex anomalies. So also there are MRI and 3D ultrasound that are used to evaluate these anomalies. There have been multiple studies that have compared these two modalities. One study demonstrated that MRI had a slightly greater diagnostic accuracy with an area under the curve of 0.92 compared with 0.88 for 3-dimensional ultrasound. MRI remains the preferred imaging modality for evaluating complex Müllerian anomalies because it visualizes the entire pelvis and associated abnormalities. However, the combination of MRI and 3D ultrasound provides the highest diagnostic confidence most of the time and can improve treatment planning. Accurate imaging has many important clinical implications. In adolescence, early identification of obstructive anomalies allows timely treatment before complications such as endometriosis develop. For women of reproductive age, the correct identification of the anomaly helps guide fertility counseling and treatment decisions. Imaging is also crucial for surgical planning, so that the surgeons can avoid injury to surrounding structures and reduce post-operative complications. Finally, renal anomalies commonly occur alongside Müllerian anomalies, so imaging should always include evaluation of both kidneys. So to summarize, Müllerian anomalies affect around 5 to 7% of women and can present with pelvic pain, amenorrhea, infertility, miscarriage, and other reproductive complications. MRI and 3D ultrasound are the most effective imaging modalities for diagnosing and classifying these anomalies. When evaluating these patients, clinicians should also consider renal abnormalities and the potential presence of endometriosis, especially in obstructive anomalies. To conclude, Müllerian anomalies arise from the disruption of normal embryologic development of the female reproductive tract and can significantly affect reproductive health and quality of life. Advances in imaging, especially MRI, have greatly improved diagnostic accuracy and classification, while the updated ASRM system provides a more comprehensive approach to these abnormalities. As imaging technology continues to evolve, radiologists remain central to the diagnosis, treatment planning, and multidisciplinary management of patients with these anomalies. Thank you for listening.